Yeah. Good evening, esteemed faculty members and all the delegates. Thank you for joining. This is Sahiti on behalf of Shield Connect, welcoming you all for today's webinar on Old Controversies and New Strategies, organized by SAFOG on occasion of World Cancer Day. So let me introduce the conveners of today's webinar. So before that, let us start the webinar with inauguration song.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तुते दीपज्योतिर्नमोऽस्तुते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः
So it's my privilege to introduce the conveners of today's webinar, Dr. Niranjan Chavan, sir. Sir is currently the professor and unit chief at LTMMC and LTMGH Sion Hospital, joint treasurer of FOXY, president of MOGS, and member oncology committee of SAFOG. Sir has many accolades to his credit, and I welcome you, sir.
Thank you.
So let me introduce the second convener of today's webinar, Dr. Bhagyalakshmi Nayak ma'am. Ma'am is Professor and HOD, Department of Gynecologic Oncology, AHPGIC, Cuttack, member of Oncology Committee, Suffolk, Governing Council member of ICOG, Chairperson Oncology Committee, FOXY from 2018 to 2020, and also Honorary Secretary of AGOI. I welcome you, ma'am, and I hand over the session to conveners.
Thank you, Dr. Alia ma'am, for introducing and getting us all together on this World Cancer Day, February 4th. And the topic today, as you are all aware, is under the leadership of Dr. Sham Desai, sir. He is the president of SAFOG, and cervical cancer still remains a problematic issue in our SAFOG countries. In India, it is the second largest cause of death in women, and we are all working hands to hand with all the nations being there today. And we have a wonderful topic for discussion. The SAFOG World Cancer Day CME is on old controversies and new strategies. So I would request now the oncology chair of the SAFOG from Pakistan, Dr. Alia Begum Aziz, to give her welcome address. Saiti, can you just show madam's slide? Yes. To introduce Alia madam, she is having the second term as a SAFOG oncology chair, and she is FCPS MRCOG. She is working in the Department of Obstetric and Gynecology, Aga Khan University Hospital, Karachi, Pakistan, and her main field of interest is gynecologic oncology. Over to you, ma'am.
Thank you, Niranjan, for this kind introduction. On behalf of SAFOG Oncology Committee, I welcome you all to this exciting event. As you are all aware, today is the 4th February, which is celebrated as the World Cancer Day. And we have decided to talk about cervical cancer, as we know that it is an important topic for low middle income countries, which include all SAFOG countries. The 4th February World Cancer Day is a global initiative which is led by the Union for International Cancer Control, and it is aimed to raise worldwide awareness, sharing knowledge, and catalyzing personal, collective, and government action. And by this, we are all working together to reimagine a world where millions of cancer deaths are prevented, and access to life-saving cancer treatment and care is equitable for all. So based on this theme, we have planned this webinar, and I'm thankful to Professor Shyam Desai, chairperson of or chairman of SAFOG uh, uh, committee, SAFOG, to guide us towards this topic, and all his support, his and Secretary General Professor Farhana Diwan, they were all very supportive and instrumental in letting us take this. And I'm very thankful to all the esteemed personalities from around the globe who have joined us today. And I would like to thank our guest speaker, Mr. Giri, S.K. Giri, who is going to give a very important talk, and our esteemed panelists from all around the SAFOG globe who are going to join us for an interesting discussion. So I warmly welcome you all to the presentations from the experts and look forward to a stimulating discussion ahead. Thank you, everybody, all the participants and all the esteemed faculty and the panelists. Thank you. Thank you, Niranjan.
Thank you, Dr. Alia. This was our chair, Dr. Alia Aziz Begum from Karachi, Pakistan, giving the welcome address. Thank you for that insight on the World Cancer Day, madam. We move ahead now, and I call upon our chief guest, Dr. Shyam Desai, sir, who is the president of SAFOG, to give his chief guest address. Sir, as you know, is from India, and he is a past president of FOXI, of MOGS, and of IAG, that is the Indian Association of Gynae Endoscopy. He is the vice chair of ICOG in 2006. He is a teacher. He has also taught me in Wadia Maternity General Hospital, where I was a student. Thereafter, I was a lecturer, and he has immense field of interest in the field of endoscopy and cancer. He is presently the chair of the board of trustees of Mumbai Obstetric and Gynecological Society. Welcome, sir, and I request you to give us the chief guest speech.
Thank you, Dr. Niranjan, for this introduction. Now, you know how important it is to diagnose cancer as early as possible, to treat it adequately, and follow up so that we'd have a good 5-year survival and 10-year survival. Now, in fact, they have said that cancer is on the increase, and various types of cancers are being detected to a larger extent, gastrointestinal cancers as well as cervical cancers and gynec cancers. Now, Dr. Alia Aziz has done a remarkable job in her first tenure as the chairperson of Oncology Committee of SAFOG. And in the second year also, she promises to do a lot. I'm expecting a lot from this committee because all of you are very enthusiastic and all of you are very hardworking. And so therefore, I feel that Alia, you should raise your level to a greater extent, try and get some statistics, try and get some data as to what are the various types of cancers that are seen in women, as well as try and see the survival of these patients and what is the methodology of treatment. Now, very often there is a cancer which comes undetected. That means a patient undergoes a hysterectomy and there suddenly turns out to be a cancer that is detected on histopath. So that is also an important situation because many of these incompletely treated cancers can increase the morbidity and mortality. So therefore, it is important to, one, make sure that the gynecologist does a DNC or does a hysteroscopy or does a pap smear before doing a hysterectomy. That is one. And suppose, for some example, there is a cancer that is residual and left behind, how does the oncologist then proceed to make sure that the 5-year survival is not affected? I wish Dr. Giri is a very senior oncologist from Cuttack, and I have known him for several years now. Dr. Bhagya Lakshmi is also very well known to me. Alia Aziz, Niranjan Chavan. So I wish you all a very good webinar.
Thank you, sir. Thank you for that wonderful insight which you have given.
Thank you, sir.
Thank you so much. And we are working on the same principles. And Madam has lined up for all the countries every 2 to 3 months programs on various topics. The first one is today. And we are going to talk about the cervical cancer. Now I hand over the mic to Dr. Bhagya Lakshmi Nayak, who is our co-convener. And may I have her slide, please? We all know she's a professor in the Cuttack, that is the Department of Gynecology Oncology, member of the Oncology SAFOG committee. She was also the chair of Oncology committee after me, and currently the honorary secretary of AGOI. She's been actively involved in the ISAR Bhubaneswar conference, which is presently going on, and also a peer reviewer in the Indian Journal of
Thank
Gynecology.
you so much. Thank you so much.
So I hand over the mic now, to Dr. Bhagya Lakshmi.
Yeah. Thank you so much, Dr. Niranjan. I think we have all put our efforts and come together today on World Cancer Day. And the crux and the theme for this year is Close the Cancer Care Gap. So I think this is a very befitting subject that we are looking at, because we know all the answers to cancer, cervix at least, but the implementation actually is the thing which has really stopped us from prevention and treatment and inappropriate treatments, about which we will be discussing today. So we have with us, really privileged to have with us Dr. Farhana. Kindly, can I have a slide? Yeah. So she is the president-elect of OGSB. She is the Secretary General of SAFOG, Head Department of Obstetrics and Gynecology at IBN Sinha Medical College. And she is the Professor of Obs and Gynae in different medical colleges from 2008 to 2016, has been the Deputy National Coordinator for FIGO PPH Bundle Project, Deputy National Coordinator for FIGO PP IOD Project Bangladesh, and a really good human being and a very good friend. So we would request Dr. Farhana to speak a few words on this very, very important day today.
Thank you, Dr. Actually, good morning, greetings, good afternoon, greetings to all. I am the president of OGSB. Actually, this was, I think, a past.
Okay, sorry, I'm so sorry.
So I think that, no, madam, it's okay. So I think that we are very important topic we are going to discuss, we will be discussed today. That is all controversies and new strategies, because every day science is developing. And Shyam sir has mentioned that I would like to also add here that proper diagnosis is very important. Sometimes we find that the diagnosis cannot be pinpointed and the treatment starts with a wrong line. I think that is very important to ensure that the diagnosis is proper. If the diagnosis is proper, of course, we can go for a correct treatment and benefit the woman. And as I was mentioning, science is changing. So every day there are new strategies are coming up and new treatment are coming up, and everybody should be acquainted. And lastly, the surgeries into all the treatment, including the surgeries, the updated surgeries should be taught to the new trainees so that the patients are being benefited. You know, the patients in the region, they are more or less the same in our countries. The pattern of disease, the treatment strategy, everything is so similar. So I think that every country will be benefited by the deliberations which are being given. So thank you so much. And I'm really very happy that I could be part of this.
Thank you so much. Thank you so much, Dr. Farhana. So I think Dr. Rohana would be joining late. He is preoccupied with some other things. So once he joins, we can have his words of blessings. So with your permission, sir, we go ahead with the scientific program. So the next session would be on very, very important talk by Giri sir, Dr. S.K. Giri, Professor S.K. Giri. So the chairpersons for this session were supposed to be Dr. Bhaskar Pal, but I think again he's preoccupied somewhere, and Dr. Ugen is here. So would request Dr. Ugen. So she is a very senior gynec oncologist of Bhutan. So madam, hello. Okay, so I think Dr. Ugen is, we cannot really hear, but Dr. Namka, he is also again a fellow in gynec oncology and gynec oncologist and obstetrician, Department of Obstetrics and Gynecology at the Jigme Dorji Wangchuk National Referral Hospital, Thimphu and Bhutan, senior lecturer and faculty of postgraduate medicine at Khesar Gyalpo University of Medical Sciences of Bhutan. So over to you, Dr. Namka, to introduce Giri sir.
Thank you, madam. Unfortunately, Dr. Ugen is at the moment little busy, so I will take her chance to introduce Dr. Sushil Kumar Giri. Sir is ex-professor, postgraduate Department of Gynecology Oncology, and former director, AH Postgraduate Institute of Cancer, Cuttack. And sir received ICOC oration at Thrissur in 2016, and also Subodh Mitra Memorial Oration, Kolkata in 2015. And he has organized many national and international conferences and workshops in gynecology. And he is an active participant who has participated in many national and international conferences. He is also an operative faculty in many ICOC conferences in gynecologic oncology pre-congress workshops. And he's a member of life member of AOGI, FOXI, IMA, IGCS, ESCO, ISO, ISSP, ICGP, SOBSI. And also he is a member of committee guideline of ICMR, NCG, NBE. And he was the president of the Association of Gynecologic Oncology of India from 2009 to 2011. And he is a peer reviewer in many of the journals, and he has received Lifetime Achievement Award by AOGI in 2021 at TMC Kolkata. And he has many papers published in international and national journals, and also he has contributed to many chapters in Foxy Books and Focus. Now I would like to hand over the floor to Sir to start this presentation.
Thank you, everybody. Now let me share my screen. So I was given the now my time starts now. So I was given the topic of discussing this matter. This is the inappropriate management of cancer service, who and why. And I put another one. This is the it's an introspection. We should introspect ourselves. How we have done it, who has done it, and how it can be prevented. And it is not the fault finding; it is the fact finding things. So now this will be in this World Cancer Day. This is closing the care gap. So now what is inappropriate status? So inappropriate means improper, inadequate, more than adequate. Is also inadequate for the concerned disease of the stage. Less radical surgery done for the stage more than figure stage 1A1, and radical surgery done for CIN, the all inappropriate hysterectomy. Another term, there is a term for inadvertent hysterectomy. This is performed unknowingly for treatment of benign gynecological condition with underlying cancer service is called inadvertent hysterectomy. What is deliberate hysterectomy? When the cancer service is known, but still you do the simple hysterectomy and do vaginal hysterectomy. This is called deliberate hysterectomy. This is the crime, what can say. So now, then what comes the appropriate management concerns? What is appropriate? If it is inappropriate, what is appropriate? Appropriate is on stage 1A1 without LBSI. Diagnosed confirmed by cone biopsy. The treatment choice can be conservative. It can be radical cone. It can be laser. It can be cryo, or it can be type 1 hysterectomy. Here is role of lymphadenectomy can be avoided. But stage 1A1 with LBSI and stage 1A2, whereas radical surgery plus there will be lymphadenectomy or sentinel node biopsy is the treatment of choice. They can do radical tracheotomy. You can do modified radical hysterectomy with type 2 or radiotherapy if not fit for surgery. But stage 1B and stage 2A diseases, the lesion less than 4 centimeter means it is stage 1B1 or stage 2, stage 1B2 or stage 2A1. The treatment choice is radical hysterectomy, pelvic lymphadenectomy, sentinel biopsies, or concurrent chemoradiation. But if it is more than 4 centimeter lesion is there, this is stage 1B3 or stage 2A2. The controversy starts. There are many data, many literature who is saying that the treatment choice is concurrent chemoradiotherapy. There are few proponents, they say radical surgery followed by radiotherapy. There are other discussion maybe on neoadjuvant radiotherapy or chemotherapy plus radiotherapy followed by surgery, or chemotherapy radiotherapy followed by surgery. All things will be there. And advanced cases there is no much of controversy. we may do extraordinary radiotherapy plus chemotherapy, concurrent chemoradiations plus brachytherapy, or we should be ready for palliative care. We should know about it. But simple hysterectomy in stage 1, A1, more than A1 will be just a minute. This will be or with LBSI or high stages is called inadequate or inappropriate management, which I told earlier. So there is a rider. There is a rider in the sense. So is it always inappropriate? Yes, that it's not always there. Less and less is more and more. There are a few data are coming that we can do less surgery, but there should be a strict guideline. In what are they? They are practice-changing guidelines. Results. There is CONSERVE trials in 2021, LASER trials 2023, SAFE trial 2024, and more trials are going on. It is incoming data are there. There are enough evidence of less or non-radical surgery following a defined criteria are there. There you can do conization, simple tracheotomy, and simple hysterectomy with or without lymph node assessment is in low risk cases. Then what are the low risk cases? There is tumor less than equal to 2 centimeter, superficial stromal invasion less than 10 millimeter, absence of LVSI, and negative lymph node on imaging. In this, if you do the simple tracheotomy, simple hysterectomy, or conization with or without lymphadenectomy, there is a fewer complications or similar long-term oncological outcome. These are coming up in a very great way. So at least we can in the low risk cases, one can think of going for simple hysterectomy. And if somebody has done hysterectomy, but all these features for low risk cases are there, perhaps we can avoid doing further treatment. And GOG 278 is a prospective study evaluating the impact of non-radical surgery, that's extrafacial hysterectomy or cervical conization or pelvic on quality of life. This is ongoing. This will over by 2021. So then what a caregiver, what he or she should do? This is a preoperative clinical staging for evaluations, treat as per stage, and for surgery, once she should learn the pelvic anatomy, she should know what is the creation of spaces, she should adequate margins, she should know how much margins she should take, adequate number of node retrieval, there's a nurse sparing surgery, and to be prepared for any eventuality, because it's a radical surgery that we are dealing very close to the vessels, there is chance of injury. We should be prepared for the eventualities and be a good counselor. We should counsel before surgery, before treatment, and to be prepared to a palliative caregiver. So if you know from very beginning of the treatment of cancer, one should know how to counsel that yes, she may recover, she may be resistant, all these things. So we should be ready to give a care, and this is a palliative care. So this is the pelvic anatomy, and this is the broad ligament, and this is the adnexal triangle. So these are all things we should know first. And this is the uterosacral ligament. This is the pararectal space. This is this is rectovaginal space. So and now we should know these are all this pararectal space. All this ureter is there. This ureter. This is paravaginal space, paravaginal space, paravesical space, and this. But during the surgery, one should be very careful that yes, we may encounter the double ureter on both the sides. This is not that common, but yes, we should be very ready that we may have double ureter, and if you injure one ureter, yes, one part of the kidney is lost. We may have to go for nephrectomy or partial nephrectomy. So you can see these are the bilateral double ureter. And this is a vascular. This paravertic area is rarely we do in cervix, but one should know about the anatomy. This is the left renal vein. This is the left renal vein. This is the IVC. This is the aorta. This is inframesentery artery. And you can see these are the live things, and these are nerves, sympathetic nerves. So then, what to do? Surgical management. How to do it? It may conventional by abdominal radical hysterectomy. Laparoscopy was done earlier, but after the RSCC trial, we have almost abandoned this laparoscopic radical hysterectomy in the case of CS cervix. And now robotic also, yes, I don't know what will come out. There is a trial going on robotic, the robotic assisted approach in cancer cervix, and the result is awaited, and we can know whether we can do robotic surgery or not. But oncology principle to maintain with adequate surgical clearance and comparable outcome. So these are we should have the adequate vaginal margins, parametric margins, and depending upon the situations, we should do treatment. And then question comes, if it is appropriate, then why there is inappropriate management? Why it is happening now in our state? This is not happening in our country or in the developing country. It is developed countries. There's a lot that are coming from USA, UK, and other countries regarding inappropriate management of cancer service. They tell it is inadvertent because they did not know earlier. But why they didn't know earlier? Why didn't they evaluate? Which are factors we need to know? So I have divided into patient factors, social factor, and surgeons or other factors. So patient factor means she is poor, she is confused, she is not able to decide whom to visit for a problem. There's a problem going on in her in a genital tract. There is bleeding, PMD, there is a contract bleeding, and she's go to wrong persons for the right cause. She has got right disease, and she go to wrong persons, or the right person does it wrongly. If she has come to me and I have done a simulated to him and I have done the blunder, and she has no or minimum access to the medical science and personnel, nor she has enough health education regarding to whom to go. She is poor, prefers to be treated nearer to her residence by anybody available with minimum cost, minimum expenses. This is her state of affairs. Now question comes, what is the social factor? So there is definitely, we know there is definitely disproportionate doctor-patient relationship ratio. But healthcare planners are not able to provide healthcare facilities for all communicable diseases, and this is a non-communicable disease. I don't know how they will going to react on it. But luckily, now the government of India is planning to go for a universal vaccination for cancer service, and this goes in a very long way to prevent this cancer, and we don't have to face all these things. And economic status and education of the society need to be elevated so that she has the freedom to think and spend on her treatment. This is the social factor. The other factor is most important, that is surgeons and other factors. Surgeon factor means there are a good number of operators than surgeons. Then who are operators? They operate only. They do not know whom to treat, how to treat, and how much to treat. But there are surgeons, they know when not to treat. This is the difference between surgeons and operators. It takes long years to experience, get the experience of when to say no, that this patient does not need treatment, does not need surgery, requires radiotherapy, does not need treatment, medical treatment. All these things needs a lot of experience. So then what happens? There is a controversy or wrong preoperative diagnosis. Patient has come, she has come with some discharge, all these things, and we have done it wrongly. Diagnosis was done and did hysterectomy. And there is complacency. I have done so many cases of hysterectomy, all this. Why cannot I do it? Let me do it. And competency. Competency means I am competent enough to go for all these things. This is decision versus decision. I can decide. Everybody can decide, but to decide do or not to do, how far to do it is again decision is most important. Confidence, false ego. I have done it. I'll do it. And there is one point is concept of oncology is lacking in many of them. That's why things are coming in a bad way. And one is cosmetic. Cosmetic means small incision in a case of cervix, and they do not. Then the approach to the pelvic lymph node is not comfortable, so they leave it just happy with it. So there is another is commercial motive. So a person has come to me, why I will leave it to others? I will earn out of it. And conscience. If you ask your conscience, perhaps things will be done in a better way. So there is a different raw evidence I'm going to give. These are case studies. So she is a case 40 years presented on 20th of 2007 with abdominal hysterectomy 3 months back for contact bleeding. Think of, she has come with contact bleeding, not evaluated. After surgery, cervix felt friable. The surgeon diagnosed as cancer cervix, and specimen is given to the attendant for HP study with comment that she will not survive as she is having cancer. Okay, now question comes, patient attendant, what did they do? They belong to a Bay of Bengal area. The Bengal area, they did the surgeon and patient in the Bay of Bengal. She is going to die. Why should I do histopathology, spend money? She's going to die. So resurgence was done on. Resurgence means emergence. So on assumption, so she came to us. There was no evidence. Voltage already healed. So what to do? You cannot, without evidence, you cannot give any treatment. So we had to wait for 6 months more for fault recurrence to occur. And she is still on regular follow-up on treatment, received radiotherapy, and she is on regular follow-up. And more than 15 years, she's alive. She's alive. She was asked that she is going to not going to live further. And this is concept of oncology and ignorance. I say this is ignorance, and concept of oncology is not there. One patient of 66 years, 20 years, menopause 20 years, present with third degree uterovaginal prolapse with PMD. So when the case is coming with PMB, see there is cervical, there is a decubitus ulcer or not, or try to do an ultrasound to see the endometrial thickness, how much. So we should evaluate. She underwent orbital hysterectomy on again on this time, but after she 1.5 months later, she came to the concerned person with histopathology report. It was stomach muscle carcinoma. So and she on clinical evaluation, the vault is already healthy, it has already healed, and no adjuvant treatment is advised. So what happened? Presented on again after 2 years, 2 years on bilateral immune and lymphadenopathy with left ulcerated with bleeding TB for 1 year. Biopsy from the vault and inguinal mass shows stomach cell carcinoma. This is negligence. Sees that patient, you see there is a bleeding on one side and there is a growth here. So this is the negligence. This is the negligence on our part. Another person presented with PMB2 episodes 1 year back, water discharge for vagina 1 month, and suprapubic mass. There's a mass in suprapubic area. Menopause 5 years. Ultrasound reveals multiple fibroid uterus with 1 at cervix. Ultrasound shows multiple fibroid uterus and 1 fibroid at cervix. No preoperative evaluation, neither smear nor biopsy taken. Diagnosis was diagnosed as cervical fibroid with anemia. Okay. Now surgery was done THBSO because there is nothing, they have not seen the cervix, they have not done and pap smear, they didn't evaluate anything, but there is a PMB. And so already everything is done on ultrasound basis. So THBSO surgery done, HP came out with stomach cell carcinoma. So one happened, you could have avoided you could have done the evaluations, perhaps we could have avoided this thing. This is complacency. This is totally complacency on the part of the surgeon. So it is 33 years, female presented on 20th August 2018 with history of nephrotomy for fibroid uterus. But she came to us diagnosed as cancer cervix 3B. And if she is now treated on cancer cervix TRT, she came to us on 20th August 2018. And she was operated somewhere in Jamshedpur. Some MS surgeon did it, and already diagnosis was cancer cervix or fibroid uterus. Everything was diagnosed, and the treatment was laparotomy was done under spinal anesthesia. Total abdominal hysterectomy, cervical growth was barely adherent. Cervical growth is there. What is adherent? And post discharge. Cervix repair was done. I don't know what repair they have done. Cervical growth tissue sent for biopsy. And biopsy came out on June 2018. This was commercial carcinoma. So this is how this is called negligence, overconfidence, or ignorance. I don't know what I will call it. So how to manage these cases? So inappropriate managed cases are not very infrequently. We in the OPD we see not very infrequently mismanaged, improperly managed cases of gynec cancers at an OPD. They see around 5 to 50% cases they come inadequately or inappropriately attend. And they are asked for further management by some sensible surgeon. If somebody done this, please, there is a cancer has come out, please go for further treatment. This is good, somehow good. But some just I have done my job, so go elsewhere, do what you can do. No advice at all after surgery, so they come in a very late complicated stage. So what to do now? So when the general surgeon is involved, it is discussed. As a gynecologist, all gynec cases should be done by a gynecologist, but when general surgeon does all this is disgusting. But what happens when a gynecologist is the surgeon, it is depressing. So this is a gynecologist should have enough knowledge of evaluating, and they should have a confidence whether he or she can do it or not do it. She could refer to other persons who can do it. So there are reasons, different reasons. What are the reasons? Why this is happening? Because this is there are preoperative diagnosis with AB. The term is postmenopausal AB, one term which is again a difficult task to deal with. Fibroid uterus, tubular mass, unhealthy cervix, cervical dysplasia, and best known to the treating persons. So 4 to 15% of invasive cervical cancers are treated inappropriately, and there are the different authors they've studied it. Then come that is other whys to answer why. The lack of preoperative cytometry was 7 to 29%. Different authors they've done it. Inadequate evaluation of abnormal pap 7 to 21%. False negative cervical cytology 9 to 31%. So these are different authors or different years they made their statistics, and others is failure to perform indicated conations. When the conation is to be done, they have never done it. Around 3 to 12% patients. Deliberate hysterectomy in gross disease or biopsy proven cancer. This is called, this is a negligence, totally negligence, this is a crime. When the diagnosis proved cancer is there, around 11 to 25% cases, they have done deliberate hysterectomy. I don't know why they have done it, but they have done it. Most probably there is a commercial intention behind it. And 0.6% of ocular cancer service detected in women undergoing hysterectomy in benign conditions. This calls for more preoperative evaluations and counseling, more so in elderly women who are at high risk. These are all recent data. This is SAFOG obstetric gynecology 2018 and 19 also. So let us analyze our cases. 190 cases of cancer service was analyzed, and there is, but you know, after 190 cases, ultrasound was done in 175 cases. But people come with ultrasound. Ultrasound is easily available to everybody, so they come with ultrasound minimum. And perhaps one was done in 33 cases. Cervical biopsy was done in 67 cases. But one case, ultrasound done by gynecologist himself and diagnosed as cervical polyp in cancer growth in a young woman and did the hysterectomy. And period diagnosis, we have done PAPS in 33 cases and HP 67 cases. We know the treatment squamous cell was come out to a 4, and in the biopsy squamous cell came 48 cases out of 190. These are all cases where period diagnosis were done cancer service, but treatment was done in the case. So next question, primary surgical procedure performed. TSBSO 103 patients, vaginal hysterectomy 30 patients, subtotal hysterectomy 10, vaginal hysterectomy 5, and LAVS DSO in 10. And now laparoscopy has come in a big way, and everybody is thinking of going for laparoscopy. And now LAVH and TLH is coming in a big way in this case setup. And there is another one is TH with cough. I don't know, cough is not required. There is no need of cough in anywhere. We should give adequate vaginal margin. So they have done just to remain in both the boats, both the sides of the boats. One is, another is worthy hysterectomy in CIN. One is, I put this query there, worthy hysterectomy means by saying worthy is not worthy. Worthy, there should be adequate vaginal margin, adequate parameter, and lymph node decision has to be there. So it is, they have done 15 cases, they have written worthy hysterectomy in a small instance, they have done it. And that I would have done the worthy hysterectomy, and 1 or 2, 3 notes they might have collected. So, and one patient was 3% done on worthy hysterectomy in CIN. And one is called extrafacial hysterectomy, and data available in 7 patients. So one patient underwent hysterectomy without waiting for HP. So HP was sent, but the surgeon has got no time or patients to go for to wait for the HP report. And in a CIN3, NSCT was given in one case. So these are all the inadequate cases. And performer, I had an impression that most probably the young generations who are coming out fresh, they are interested in doing surgery. So they might be doing this inadequate surgery. But I was wrong. When I analyze these cases, I say the surgeons, senior gynecologist of those who have 10 years experience, the 56% cases are done by senior gynecologist, and junior gynecologist around 11% cases. General surgeons are 21% cases, and general surgeon assisted by gynecologist. You know who are the general surgeon is person who is a husband of the gynecologist, and the gynecologist is assisting him, the surgeons for the hysterectomy, and this is around 6.6%. Unknown is around 5.4%. And who is expert? Expert is one who knows more and more about less and less. So the place, this is obvious, the private hospital place is commonly done there, and government is 48%, but medical college we have got incidence of 9 cases, and this is not at all expected to be desirable at all. And mission hospital, I have seen in different mission hospital, they are doing some unnecessary surgeries and unnecessary hysterectomy in a cancer service. So now question comes oncological outcome. The survival outcome and prognostic factors post-inverted hysterectomy in carcinoma cervix treated with salvage chemotherapy or radiotherapy. This is BHU data. This was in 2023. They have 198 patients, median follow-up for 45.5 months. And normally the risk of recurrence is 34.6 to 60% without adjuvant treatment. But they've given adjuvant treatment, and adjuvant treatment mostly in form of radical concurrent chemoradiotherapy, or they can go for, one can go for radical parametrectomy or vaginectomy and lymphadenectomy. Their 5-year survival, PFS, overall survival was 75% and 76% respectively. So after adjuvant treatment, so the inferior ovarian survival PFS was detected in their study when residual disease is more than 6 centimeter. Cutting through the diseases, when you're cutting the disease, there is more chance of recurrences, more chance of morbidity is there. And when there is gross lymphadenopathy and non-squamous histology, usually adenocarcinoma or other there is more chance of resistance and morbidity and failure is there. And prolonged overall treatment time. If a person has come with hysterectomy today and you plan for radiotherapy, you should be completed within 12 weeks. The more you delay it, the more problem of chances of survival is there. So this is again this is a Guwahati Cancer Hospital. They've done it in 2020. They've done only 38 patients with 36 month follow-up, and a PFS of simplicity with involved parameter PFS is around 50%. It ranges from 50 to 80%. Involved vagina PFS when this progression phase survival is 75%. Growth more than 4 centimeter PFS is 85%. Adenocarcinoma PFS is 42%, 8% versus squamous cell carcinoma 81.5%. So adenocarcinoma PFS is poor. When there is poorer prognosis found in when there is positive margins, when gross residual disease at the paracervical area, and time elapsed between the surgery and radiotherapy, it is more than 12 weeks. So this is one where is this is from Bangkok. This is a gynecology journal. This was in 2019. 10.8% cases detected after hysterectomy. Small tumor with simple hysterectomy had a similar oncology outcome after appropriate subsequent management. Means if it has come with small tumor with a hysterectomy done. So if you do parametrectomy, lymphadenectomy, vaginectomy, or do adjuvant concurrent radiotherapy, perhaps the result is same. Result is good. But and DFS is 93.2% in improved hysterectomy versus 88.4% standard radiotherapy. So there is no difference at all in treatment. But there is increased radiotherapy related morbidity. So definitely, if you give both treatment to be given, if given, there is morbidity is more. So what are the radiotherapy related morbidity? There is radiotherapy proctitis, radiotherapy cystitis, radiotherapy vaginal stenosis, pedal edema, DVT, and BBF. They are the commonest complications which can occur if you give adjuvant radiotherapy along with hysterectomy. So perhaps we should aim not to have 2 treatment at a time. One is surgery plus radiotherapy should be avoided as far as you can. So can you do something within all the particular? Can you do something? Yes. Look into yourself whether justified or not. Dr. Sam has told. Look into, put a speculum, put the hysteroscopy, do the DNC, do the endoscopic kilometers, all these things. Look into the patient as your own. If she has come as your own relations, what you will do? Think the same thing to your patient. Look at the cervix, at least put the speculum vaginations if you cannot do VI. Look into the endometrium, look into the abdomen, look deep into the subject, the science and arts. We should know deep into the subjects, otherwise, and not the commerce aspect. Try to look into the science and arts, not the commerce aspect of it. Learn and earn. You learn what to do, then you try to earn, not the earn and learn. So there is 4 S. One is acquiring adequate knowledge. Society improving status of people at large, both education and financially. This is the role of healthcare planners. Self-analysis. I should do what I have done. I should analyze myself, assess, and proceed. And that's the proper documentation of the procedure, right or wrong. What I have done, document it. So maybe it will be easier for others to treat accordingly. And adherence to the fixed evidence-based protocol will give a better result. So this, what is this picture? This picture is in Bihar, some colleges, some school. There is +2 examination going on. People are supplying copies. The teamwork. So cancer treatment is a teamwork, not like this. It should be different way. So this is my favorite slide. This is a look. These are very small, very cheaper instruments. You can put the speculum. You can put the you can take a smear. You can, and then this lesion can be done. And if you require, you can go for colposcopy. So one question is, जहर का स्वाद सीप से पूछो, हीरा से पूछोगे तो अमृत बताएगी. मोहब्बत का अर्थ राधा से पूछो, रुक्मिणी से पूछोगी तो अधिकार ही बताएगी. वनवास से विरह का दर्द उर्मिला से पूछो, सीता से पूछोगे तो धर्म ही बताएगी. और लॉकडाउन के दर्द गरीबों से पूछो, अमीर से पूछोगे तो मजा ही बताएगी. So this means it pinches who suffers. So a person who suffers, definitely he or she knows the pain behind it. So better don't ask anybody else who is not sufferer. Then what we gynecologists should do? Have adequate exposure with training, oncology bent of mind, and evaluate then decide. Listen to the seniors' advice and learn to upgrade. A nice line said by the father to his child: always listen to my advice, not because I'm always right, but because I have more experience of being wrong. So from that, you listen to the seniors' advice and learn and earn. Surgeons should not overpower. Don't make mess of everything. ABCD, I tell you, ABCD anybody can do. Dedicated training and not exposure. Mistakes are inevitable. Yes, ability to mistakes, accidents are inevitable. Try to learn from mistakes, not from yours, but from others, and be selfish in that way. So after surgery, document this is right or wrong, and labeling of samples or orientation should be done. So this is another interesting case of documentations. A case of PMB 1 year, cervical growth infiltrating 4 centimeter, confirmed diagnosis by staging, PPPR HP, diagnosis cancer CSRB 2B after clinical evaluations and examinations, and she has given NACT for 3 cycles, and radical surgery done in September 2012. Documentation, that you see how documented this is radical hysterectomy, R0 at vaginal margins, R1 is at bladder base, R2 at parametrium. Do you know what is R means? R means residual disease. Residual disease at parametrium is 2 centimeter. So you can see. So this is called, what I call is height of documentation. The documentation means the person has done very nice documentations, and so this gives you how person is well oriented in a cancer treatment. After surgery, one should do pathology requisitions. It should not be there. It should be prasadified. It should not be prasad. What to do prasad? Prasad means just distribute from this person to others. This is. If you do prasadification, means person of the tissue is given to one laboratory, other person is given to other laboratory. Now there is confusing reports because they want some part of the tissue cannot be harboring the disease. So that there is controversies and confusions of the report. When there are 4 or 5 laboratories comes the report, one is positive, one is borderline, one is suspicious. All the things it gives. So once it should be given to one laboratory whom you believe, whom you trust. Then if you do not get the result, the result is not after satisfaction, tissue should be given to some other places of your choice. And one should introspect here. So what to do, what not to be done. I expect and I wish gynecologists should avoid small incisions when in doubt. Avoid laparoscopy for all. Have detailed knowledge of pelvic anatomy. Get ureterophobia, gain knowledge of pelvic anatomy. Not be panicking about vascular injury or any injury. Should know how to manage. Never hesitate to cry for help. Always, when there is a problem and you are not very confident, very comfortable in managing, ask for help. Yes, people will around you to help you. And there is professional training may widen the visions, and there will skill development will be there. So we know there are a lot many training in India is going on. MCD Gynae Oncology started in 2000. It was allowed in 2016 and it started in 2011. And we have got 28 seats in India in different centers. And DNB around 15 seats in different centers in India. And the fellowship programs at different centers also going on. Sorry. And training duration is postgraduate in obstetric gynecology. This is only postgraduate obstetric gynecology are allowed to go for the training. And this is for 3 years recognized courses. There is also FNB courses there, but DNB is preferred because it's 3 years courses. So coming to the last point, this is to say a few words. To err is human. So human error plays a role in inadvertent improper hysterectomy. So inadvertent hysterectomy that is a human error I can think of. But what will deliberate hysterectomy in case of biopsy-proven cases? So one should not do this blunder at all. Operating on inoperable cases, whether error of judgment or deliberate or for financial gain. When there is a cancer TB is there and we plan to operate and do the subretinal hysterectomy. Whereas I don't think it is of any scientific reason behind it. Whereas most probably it is deliberate and it is a financial gain. And the working hysterectomy says CIN3, are you justified in that? The poor man is not everybody's domain. poor woman is not everybody's domain. So everybody has no right to do anything on this body of this poor woman and do treatment inappropriately. The management of inadequately treated patients poses problems to the treating persons or patients. It increases morbidity and decreases survival. And one should find out the accountability of the person who has done. It is not yet done in our country, but one should there should be accountability on the person concerned. And there should be confidential inquiry to probe the need of the day to find some way to prevent such blunders or crime. And close adherence to screening and evaluation guideline in gynae cancers will prevent this. Training, reorientation, superficiality in gynae oncology is a call of the day. So our prime purpose in this life is to help others. And if you cannot help them, at least do not hurt them. At least do not hurt them. And this is a so usually we ask not to do unnecessary cases, but thank you. Let me close here. Thank you very much.
Thank you very much, Professor S.K. Giri, for a very beautiful and elaborate presentation with live example about inappropriate management of cervical cancers, why and who. I'm sure with your presentations and some of the great examples, all of us will now be very careful in screening and treating the cervical cancer, and all of us will try our best to give the most appropriate treatment. So before I hand over the floor to the convener, I would like to raise a suggestion in the floor. In the European countries nowadays, they have shifted from radical hysterectomy to total mesometrial resection for the treatment of cervical cancer. So if since we have some time, if sir has any experience or opinion in this regard, it may be useful to the audiences.
To be frank, I don't have much experience on these total mesometrial resections, but yes, this is a very you can say embryonic type of dissections can be done, but I don't have any experience, and perhaps sometimes I feel it is not that much required in our country when the patient load is much, and we have to treat patients not only cervix, ovary, endometrium, all these things in a day. So perhaps but it takes time, and it's a good inventions of Huckel's. This is Huckel's inventions, and one can do that. I don't have experience on this. Anybody who has experience can elaborate.
No, sir. Actually, we don't have any first-hand experience with that, but then that's a very evolving field now. So that's according to the ontological or embryological compartment theory for the surgery. So that even in advanced cases, if you do, they believe that it does not cross the compartment. So even in advanced stages, if you can remove the entire embryological compartment, then you would not need chemoradiotherapy. But then I think only 3 centers in Europe are doing it. So I think it will take some time, though it has the idea has been conceived long back. I think still it has not picked up very well. Maybe the surgery is little very challenging. So I think it will take some time, and maybe we'll do it. And Dr. Alia, yes, I think she has raised her hand.
Yes, we had some experience because we attended a course in East Germany by Professor Michael Hockel, who is the pioneer for TMMR, and we invited him once to Pakistan to do this live surgery for us as well. And since then, we've done some TMMRs, and we are doing maybe not the actual TMMR so far because of the time constraint and resource constraint, but we are doing nerve-sparing radical hysterectomies, trying to do the same principle. And I'm happy to say that all my fellows who are trained in my institution are trained for nerve-sparing type TMMR, so that I'm very much convinced that the Michael Hockel's principle of embryologic compartment is true, because all those TMMRs we have done, they have survived, and so far we haven't seen any recurrences. I understand in LMIC we do have constraints, because when we do TMMR, it takes a couple of hours. So in public sector hospitals, we can't have 4 to 5 hours for one surgery. But once, if you have time and if you have resources and if your patient selection is good, then it does lead to good disease-free survival and overall survival. So I would encourage anybody who wants to train into it, please attend some courses, and because I think senior gynecologists need to actually observe one, understand the principle, and start doing it, and you can do it.
Yeah, recently I also attended one short training at Armenia with Professor Artem Stepanian. He also learned from Professor Michael Hockel. And I found it, the TMM are not very much complicated as compared to requestectomy. And I think it is possible to do it with a little bit of exposure, as Madam said. So in the interest of time, I would like to end this session and hand over the floor to the convener, Professor Bhagya Lakshmi Nayak.
Thank you, Giri sir, and thank you, Dr. Namkha, for conducting the session so well. And so we move ahead with the panel discussion today. So we have Dr. Niranjan Chavan is the moderator, so I'll be co-moderating with him. So I think he has already been introduced. So can we go ahead with the next slide, please? Yes, please, next. Yeah. So we have very senior gynae oncologist with us, Dr. Uzma. So she is from Pakistan and has done her clinical fellowship in gynae oncology at Royal Marsden Hospital, UK. She is assistant professor and consultant in gynec oncology and associate director of the fellowship program of gynec oncology and in Department of Obstetrics and Gynecology at Aga Khan University Hospital, Karachi, Pakistan. Next, welcome, Dr. Uzma. Then we have Dr. Shahana Parvin. Shahana is from Bangladesh, Dhaka. She is a professor in the Department of Gynec Oncology at the National Institute of Cancer Research and Hospital, Dhaka. And she is trained in gynae oncology at the Massachusetts General Hospital and Harvard Medical School, Boston, and many other institutions as well, including Italy, Singapore, etc. And is a life member of many associations and has many publications. So welcome you, Dr. Shahana, to this interesting session. I think Namkha has already been introduced. Next. So I think Dr. Inaya will be missing her out. So in place of Dr. Inaya, we will request Dr. Alia to take some of the questions. And we also have Dr. Sampath Kumari, madam. So she is a professor and HOD of Sri Muthukumaran Medical College Hospital and Research Institute. She has been the vice president of FOXI, Senate member of DR MGR Medical University, national corresponding editor of Journal of OG of India, founder secretary of Tamil Nadu Federation of Obstetrics and Gynecology, and she has many accolades and actually is a very, very active person and was also heading the adolescent committee of FOXI. So welcome you, Sampath Kumari, madam. Next, please. And we have with us again Dr. Rajita Vijayasinghe, who is from Sri Lanka. And he is a board certified specialist in gynae oncology, trained in Royal Surrey County Hospital, UK, and works in Sri Lanka, UK, and Australia also, and is a co-author of the Sri Lankan Guidelines on Gynecological Cancers, and currently working as a consultant gynae oncologist at National Hospital in Kandy in Colombo. So next, please. And we also have with us Dr. Jitendra Pariyar from Nepal. And I think he is a very known fellow in all the SAFOG meetings. He's there. He is a gynae oncologist in the BP Koirala Memorial Cancer Hospital and has done his fellowship in Seoul, Korea, and is presently head of Ops and Gynec Department of Civil Service Hospital, National Cancer Hospital, and Nepal Cancer Hospital, Kathmandu. And he is a mentor IGCS Gynae Oncology Global Curriculum and Mentorship Program, and that his program is doing really very well in Nepal. So, and he has also been the Oncology Committee Chair of NESOG, Vice President of Gynecological Oncology Society of Nepal, and many other things. So, welcome you, Dr. Jitendra, to this important meeting. Next. Yeah. So, thank you. And So I will be sharing the screen. The first case will be taken by Dr. Niranjan.
Thank you. We also have our expert, Dr. Sabira Khatun, and I would request you to show her slides, show her introduction. Dr. Sabira Khatun is also a part of an expert for this panel. Thank you, madam, for joining. She is from Bangladesh, and we all know she is a co-chair of the oncology committee of SAFOG, a founder chair of the Department of Gynae Oncology of Banga Bandhu Sheikh Mujib Medical University. She is very curious and inquisitive, and I have valid points when she is with us. And we have seen her very dynamic personality. She was also the founder president of Bangladesh Society of Colposcopy, Cervical Pathology, and a founder chair and the secretary general of Gynae Oncology Society of Bangladesh. She has written many books, so we will get her expert comments also at the end of the panel. And thank you, madam, for joining with us. So now I would request Dr. Bhagya to please share the panel discussion today. On the occasion of the World Cancer Day, we are going to talk about inappropriate hysterectomy cases of carcinoma cervix. Can I have the first slide? We
Is it
all
visible?
Yes, it is visible. Thank you so much. Can we have the next slide, please? Yeah, so I welcome all the panelists and thank you, Bhagya, for taking efforts for presenting this presentation and the cases. I welcome all of you. We have been represented by each one of them from the countries of SAFOG. So we will go to the first case. The first case is a 45-year-old lady. She was referred for a vaginal hysterectomy. She had a second-degree descent. Next slide. So normal menstrual cycle, a fourth gravida, para, and she was on OC pills for 10 years. And 2 episodes of postcoital bleeding was there, and that's where she was then referred to a gynecologist. Her examination findings were quite normal as such. The cervix was broad. That was the only thing which was seen, and the pap smear showed HSIL, and colposcopy was done. It showed CIN2. Ultrasound was normal. Fornix was clear. The uterus was bulky. Next slide. So she was posted for a vaginal hysterectomy. There was no significant intraoperative findings on doing the surgery. Uh, 2 to 3 small pieces of cervical tissue were taken, and they were undergone a microscopy, and it turned out that she has squamous cell carcinoma, moderately differentiated. There was no comment on the depth of invasion and on LVSI. Next slide. So, absolutely the vault was healthy on examination, everything was fine. So now the clinic could not provide the whole specimen. Only the cervix was sent for histopathology somehow. And then with this limited pathological information, she was referred to the oncology department. Next, please. So, what are the evidences for further management? I would request Dr. Uzma Chisti and any other panelist who is there to come forward and go ahead with their opinion about this further management and what are the evidence. Dr. Uzma.
Yes, thank you very much. Am I audible?
Yes.
Okay, thank you very much, Dr. Chavan. So this is the dilemma we all face off and on in our clinics when a patient with inadequate surgery comes to us, or after the simple hysterectomy, we found that there is a cancer. So first and foremost, we have to look forward and see the histopathology, whatever the information is there in detail, and try to find out what was the lesion size and depth of invasion. So in this case, as you have mentioned, that there is a very limited information already available, and there is a cancer which is moderately differentiated. So I believe that the evidence suggests that, first of all, we have to find out about the local and the metastatic spread, and the workup should be done in detail. So in this case, I would recommend to go for Walt smear as well as some imaging to look at the local spread and the distant spread to rule out any upper abdominal disease or any pulmonary disease. After they exclude metastatic disease, then there comes a question that whether this patient needs any further treatment or not. And then if the Walt smear comes out suspicious of cancerous cells, or the PET scan or the CT scan shows there is any lymphadenopathy, then definitely this patient needs further treatment by means of either the parametrectomy and radical procedure, including lymph node excision, or CCRT, means combined chemotherapy or radiotherapy if required. So it will all depend upon its workup, metastatic workup, and the results of the Walt smear. Thank you.
Yeah, just a minute. Give me a minute. This show about sharing. Yeah, can you see the slides?
Yes, if you can put that on the slideshow, please. Yeah.
Okay. Yeah. So I think Dr. Uzma has been very, very clear that. So we would really like to know, Dr. Niranjan, would you like to go ahead with this?
Yes, yes. Evidences are there. There are some papers we would like to share with all of you. Especially when you have such a case of a simple hysterectomy being done and it turns out to be an occult invasive cervical cancer. Whether we should go ahead and do further lymphadenectomy for this case or whether she should be subjected to radiotherapy. So all these points have been discussed, and can we go to the next slide? Yes. So they have similar therapeutic effects, and this is another paper by Yumin Bai. It has been published in 2016, where a simple observation after a lymphadenectomy procedure may be feasible in this occult case of cervical cancer, invasive, where the tumor width is less or equal to 20 millimeters. Superficial stromal invasion and a negative section margin in hysterectomy specimen and no LNM. This is one paper which has been published. Next week we can have another one more by Fibres. This is also where an inadvertent simple hysterectomy was done in the Annals of Surgical Oncology being published. Your radical parametrectomy with pelvic lymphadenectomy using minimal invasive surgery seems to be more efficient than radiotherapy or a concurrent chemoradiation. And of course, with acceptable minimal morbidity being observed. So, we have different school of thoughts now. We can see radiotherapy or just minimal invasive surgery or some parametrectomy. Anyone panelist would like to share their comments on what Dr. Uzma has
I
said?
think Dr. Uzma has again raised hand.
Yes, please.
Okay, if I may add something. So in our case, which we just discussed, we didn't have the complete histopathology available. But if we have the complete histopathology available with the depth of invasion and comment on LVSI, and if it is clear that the disease was very initial and it was 1A1, then we may not need to go in for any further treatment. As the studies suggest that if there is an observation of these type of cases with 1A1 occult disease, then there is no risk of recurrence. But if the disease is more than 1A1, then definitely some sort of treatment after the metastatic workup is mandated.
Absolutely, yes. Dr. Bhagya, would you like to add here?
Yes, I think every case is not the same. So we need to have a complete histopathology. So that's very, very important. So here we can see that we have the NCCN guidelines in place that in stage 1A1 pathologic review, no LVSI, you can put her under surveillance. But then we have to be 200% sure that it's a stage 1A1. So when we see that a portion of the cervix only is sent for histopathology, we really don't know what stage it is. So in looking at that scenario, I think I would err on giving her a little higher, more treatment so that she lives instead of waiting for the recurrence to happen. So I think if we have access to the gross specimen or to the histopathology complete report, maybe the block or something, we have to assess it completely. That is more important. And I think all gynecologists who come across such a case should take all the efforts, especially oncologists, to get in touch with the clinician, get in touch with the pathologist. So in case they, and try to retrieve all the information that is possible. So I think Dr. Jitendra is also raising hand.
Can I say something?
Yes, madam.
Yes, yes.
I'm Professor Sabra Khatun. Here the case is second degree uterine prolapse and colposcopically CIN2 without doing any lip biopsy, the hysterectomy, vaginal hysterectomy done. I think vaginal hysterectomy, most of the cases, vaginal hysterectomy, the parametrium is very loose, and it's the wrong belief that the vaginal prolapse is not associated with cervical cancer, mostly because
that
of
is a myth. Yes.
wrong belief, and it is believed that the cervix is in the environment which is not suitable for development of cervical cancer, and that's why there is a wrong belief that the vaginal prolapse is not associated with invasive cervical cancer. I think with this wrong belief, the simple hysterectomy was done. But as it is this vaginal prolapse, mostly it is likely to be parametrium is free. So pelvic lymphadenectomy has a parametrectomy and bilateral salpingo-oophorectomy. I think it will be better to take the decision about the further adjuvant therapy. Without this surgical pathological report, the decision for further adjuvant therapy decision is very difficult.
Yes, Dr. Jitendra, you wanted to add something?
Yes, thank you for presenting this case, which in fact is our real case scenario. In fact, like we have UB prolapse, which is quite common. And of course, as we have noted, HSIL or CIN3 precancer is also quite common along with cancer. So I would fully agree with Professor Khatun, who mentioned that in this case, probably the treating gynecologist was considering UB prolapse as primary pathology to be treated surgically. But it seems that the gynecologist has done quite well inspecting, taking cytology, and even subjecting her for colposcopy. But after colposcopy biopsy, which was reported as HSIL, then probably excisional therapy should have been offered, which would kind of give us clear picture whether she had pre-invasive disease only along with UB prolapse or she had invasive cancer. Probably that would have changed the management, and probably better and appropriate management could have been offered. And
Okay.
in this case, I agree with other panelists. Though we have small biopsies, it is always good to have slide review and get adequate information regarding the lymphovascular space invasion and depth of space invasion. And it seems that if these are negative, probably blessing in disguise, like vaginal hysterectomy may be adequate. Of course, metastatic workup with radiology like CT or MRI after a few weeks after post-operative inflammation has subsided would be better as for the workup. Thank you.
Yeah, Jitendra, just to add to it, but one very important thing we are missing out is that the cervix was broad. So sometimes this endocervical growths will really come on the ectocervix as CIN, but the invasive cancer is in the endocervix. So that's where I think we have to be a little more careful about assessing those cases with a broad cervix. So because they have got a report of HCL on smear, they have done a colposcopy, they have got CIN2 and then gone ahead and done the hysterectomy. So, but the one pertinent finding was that the cervix was broad. Okay, so I think we have many people to speak. So I think Dr. Sampath Kumari, madam, yes.
Yes, Dr. Bhagya, why don't we proceed with that conization first? Then we can have that good idea of the conization and the nodal pathology, everything that MRI like that we can do. And then why can't we proceed for the surgery?
Yeah, I think, madam, because CIN2, because they got a report of CIN3, conization has to be done. But I think CIN2, they have mistaken it to be a lesser disease. But from the colposcopy, I could understand that it was a high-grade disease, whatever be the biopsy. So I think we have to put many things together before we plan the treatment. It's not only the histopathology, not only the MRI, or not only the look of the cervix. Yes, Dr. Ajita, you want to speak something? Unmute, please.
Gita,
Please unmute.
Yep, can you hear me? Yep, can you hear me?
Yes, please. Yes.
Yeah, I just want to raise a limitation of using a colposcopy and a smear in this situation after surgery is being done to exclude whether there's residual disease, because unlike unoperated vaginal mucosa, when you have scar tissue in it and when you do the repair, if there's some occult cancer remaining on the edges of the vaginal mucosa, it can really hide, and it might not appear outside. So you might be falsely reassured if you do a smear in this situation, or colposcopy, just to see if there's any other.
No, all this was done before surgery, Dr. Ajita. All this was done before the hysterectomy.
No, what I was saying that now when you want to, in this situation where we don't have a proper histological report, and we feel like if you're going to use a smear or a colposcopy to assess whether if there's any residual disease.
Okay, I understand. After hysterectomy, doing a colposcopy is difficult.
Yeah.
Yes, understand. Okay, thank you so much. So I think we have done with this case. So we have all the guidelines in place. So
yeah, Bhagya, I think a good discussion has occurred on this, and we can. This is also one of the paper which is there on prospective trial of conservative surgery for low risk early stage cervical cancer, and the further assessment is to be done, and etc. Can we go to the next case now?
Yes. So the only to summarize is that we have to try to avoid inappropriate surgeries and try to collect all the details from the pathologist and from the surgeon. And if there are any high risk factors, refer for the treatment. If all details show small lesion and no risk factors, then you may keep her under surveillance. So that is it. So we go to the second case. Dr. Niranjan, I take this case.
Yeah.
Yes. So she is 48 years, para 4, housewife, presented with post-coital bleeding 4 episodes in the last 1 month, irregular vaginal bleeding for the last 3 months, and on examination she was anemic. Pelvic examination showed a large cauliflower 4 centimeter growth occupying the cervix, which bled on touch, and rectovaginal examination left parametrium was involved. Clinical stage carcinoma cervix 2B, and ultrasound showed a heterogeneous soft tissue mass of 3.8 into 3 centimeter in the cervix. This was in some of the backward areas, and so this was the histopathology which showed that it is a keratinizing malignant squamous cell from irregular nests invading the stroma. And so what is would be your treatment of choice in such a case when obviously there is parametrial invasion? So Dr. Uzma or anyone else, Dr. Alia, would you take this question?
Yes, Bhagya. In this case, as the parametrium is involved, I think surgery is out of question, because if you do surgery, then we'll have to combine it with radiotherapy later. So I think the ideal treatment of choice would be CCRT or combined chemoradiation.
Yes. So thank you so much. But the problem is that once you advise your patient So once they go to a center and they are given a waiting time of 1.5 months, 2 months, then what happens? Is it the same scenario that you have in Pakistan also?
And in Pakistan, we have couple of, I would not say we have adequate number of centers where radiation can be given, but at least where I work, it is a teaching hospital and it's a tertiary care hospital. So we don't have that long waiting time. And the CCRT is planned and it is given according to this. But in public sector hospitals where this treatment is given, there are gaps. There is waiting time. It's not as long as 6 weeks, but the problem is when it comes to brachytherapy, because sometimes that external beam is given, and when it comes to brachytherapy, that brachytherapy apparatus is not working. So there are gaps in treatment. And we all know that the gaps in treatment should be avoided. So I think in LMIC, all these problems we face, and we try to go around them to give our patients benefit.
Yeah, thank you. So I think she was advised chemoradiation and ICRT, but since no facilities were available nearby, the patient did not want to go. So somehow she reached out to some oncologists in which 3 cycles of paclitaxel and carboplatin were given to her. So, and after 3 cycles of chemotherapy, she was referred back again. So there was a small growth, 1.5 centimeters. So the big growth has reduced to a small growth. On the anterior lip of the cervix, the uterus is normal size and all fornices were free. And post chemotherapy, the CT scan also showed a small soft tissue mass about 18 into 20 mm on the cervix without any parametrial or vaginal involvement, and there was no lymphadenopathy or ascites. So Dr. Shana, so she already has chemotherapy 3 cycles, and now what is the treatment of choice that you would advise her, since she has already completed 3 cycles chemotherapy?
Yes, I have a thing that in our country, cancer service patients and burden is huge. And in government sector, there is the long queue, not like I think it is the whole, the South Asian countries, the scenario that here some of the patients where in our hospital, where I'm working in National Institute of Cancer Research and Hospital, where we have every day here the huge queue of the patients. And sometimes patient need minimum 5 to 6 months. And sometimes it is minimum 4 months and sometimes 5 to 6 months. In that cases, sometimes with some private sector, the people, they do this, that is 3 cycle chemotherapy, and they refer the patients to our hospital after that. In that cases, we usually go for as we don't know the original picture, that the primary, during the diagnosis, what was the actual staging. In that cases, we usually do both the CT chest and the CT abdomen. And if there's SCT nothing, then CT abdomen, usually routinely we should not go for the surgery. Usually we should go for the radiation, the ideal treatment. As because in this low research setting, ideally the chemoradiation and brachytherapy is not possible. In that cases, if there is no visible growth and there is the minimum visible growth that is less than 2 centimeters in that sector, that may be done in there is a radiation queue, long queue. In that cases, we may do the neoadjuvant chemotherapy and followed by the neoadjuvant chemotherapy followed by the surgery. But the different studies, they don't show the both progression-free survival and overall survival superior than that of the chemoradiation.
Exactly. So that is what happened. Advice is again advice for radiotherapy as the best treatment option in the disease management group, but patient declined as RT facility gave a long date. And so after detailed discussion with the patient, a decision for radical hysterectomy was taken. So was it a correct decision? I think Dr. Shana has already answered this. So let us go. Now, Dr. Namka, would you like to discuss some of the evidence that are there for neoadjuvant chemotherapy followed by surgery? So is it a right treatment that happened? Because she had a radical hysterectomy after 3 cycles of chemotherapy.
Yeah, this is quite a difficult scenario to tell the exact answer. But in this context of the patient, where she had no access to radiation therapy, I think it was a correct treatment for that particular patient. But in general, those patients who have access to the radiation treatment, the treatment of choice should be radiation, chemoradiation.
Yes. So I think if we stick to science, it is chemoradiation, because we have had enough evidence that neoadjuvant chemotherapy followed by surgery is not the standard of care. So I think this was a paper which showed that if tumor size less than 4 centimeter, the complete response was 64.2 and 60% in 2B, and they became operable. But tumor size more than 4 centimeter, complete response was poor. But that is a different story. But here again, studies have shown that locally advanced cervical cancer showed NSCT plus radical hysterectomy achieved better overall disease-free survival, loco-regional disease-free survival, and metastasis-free survival and overall survival were compared to definitive RT. But these are anecdotal studies. We are not going to go by each of these reports. But I think this was again a URTC trial in which they showed that NSCT followed by radical hysterectomy and CTRT alone had showed comparable results. But the FIGO guidelines here, you can see very clearly states that in areas where radiotherapy facilities are scarce, neoadjuvant chemotherapy has been used with the goal of downstaging of the tumor to improve the radical curability and safety of surgery and inhibition of micrometastasis in distant sites. But there is no unanimity, and so NSCT surgery is best reserved in research settings or areas where RT is unavailable. So I think we all have to understand that neoadjuvant chemotherapy followed by surgery is not a standard of care and has to be reserved only for settings where we really can't give her the proper treatment. So I think we go to the case 3 now. So Dr. Niranjan?
Yes.
Yeah.
Thank you, Dr. Bhagia. We had a wonderful discussion. We go to the next case now. She is Mrs. X. We commonly come across such a woman around menopause, 49-year-old. She is 5 para, a housewife. She is hypertensive, non-diabetic, and on examination, we find a growth there. But before that, she complains that there is a foul smelling vaginal discharge. We find such cases also in our practice which come. Her ECOG score is 0 and there is an exophytic growth sitting on the cervix looking red, and it's friable 2.5 to 2 centimeter, and it involves both the lips of the cervix, hard, fixed, friable. And on further bimanual and PV examination, the parametrium is smooth and free. Uterus is normal size. Both the adnexes are normal. The rectal examination with one finger shows that the parametrium is free on both the sides, and the rectal mucosa is also free. Now, this is MRI which shows that there is a 2.9 into 2 centimeter soft tissue growth sitting on the cervix, predominantly on the anterior lip of the cervix, and it's more on the right, but without any bilateral parametrial involvement. The fat planes are well maintained, and the uterus is fine. The uterine cervix, there is no disruption of peripheral rim. You can visualize that. Can we have the next slide? So the diagnosis has been done as squamous cell carcinoma of the cervix, stage 1B2, grade 2. So after all the preoperative investigations, the surgery planned was radical hysterectomy and bilateral pelvic lymphadenectomy. So on 2021, 1st of March, the abdomen was opened by Maillard's incision, and the check for operability was done. The lymph nodes were palpated, and there were some few enlarged lymph nodes. However, all of them were removed except one, which was measuring 1.5 centimeter. It was fixed, and it was not removed because there was a risk of vessel injury, and the planned surgery was completed as what the radical hysterectomy with bilateral lymphadenectomy, and that fixed node was kept. This is the picture which you can find nicely, the whole parametrium, the uterine artery, and the lymph nodes which have been removed except that one. And on cut section, you find that there is a 3.3 into 2 centimeter growth in the endocervical canal. So on histopath, following sent to the pathology department, the squamous cell carcinoma grade 2, 3 centimeter, the parametrium was not involved. 10 nodes were dissected, 3 were positive, and the vaginal cuff was free. That was very heartening, and LVSI positive. So with this findings which we have seen, the patient was then further referred to oncology department in our vicinity and for further treatment. Now, I would like to ask, in view of this large lymph node, should we continue this surgery or abandon? What is your opinion, Dr. Jitendra Parikh?
Thank you, sir. Again, it's quite a difficult situation because clinically and based on preoperative MRI, this case is presumed to be stage 1B2 squamous cell carcinoma. But unfortunately, intraoperatively, bulky nodes were noted. In that situation, if the facility is available, it would have been better to sample the node and then subject it to frozen section. If that comes out to be positive, then high risk factor is there, and the FIGO of staging, it would be stage 3C1P, pathologically proven. So in that situation, it would have been better to abandon radical hysterectomy in favor of concurrent chemotherapy. But if facility of frozen section is not available, discussing with pathologist, imprint cytology can also be attempted, which seems to have comparable results in a low resource setting. So bulky node intraoperatively, I would be little bit cautious in proceeding with the planned radical hysterectomy.
I think that's a challenging situation, right? So because we have to agree that sometimes imaging will also miss out some of the enlarged nodes sometimes. So yes.
Yes. Can we have opinion of other members here? Dr. Uzma?
I would agree with Dr. Namka because when we do the hysterectomy and patient goes for CCRT, while radiation, the whole gut lies in the pelvis. And there are challenges in giving the radiotherapy along with its complications. There are more complications when there is no uterus and the whole gut lies in the pelvis. So I would definitely agree with the point that if this is an obvious disease involving the lymph node, the radical procedure should have been abandoned because not only the radiation complication, there are other certain complications associated with radical surgeries, which the patient has to bear with. So I would also abandon that.
Yeah, I have one opinion setting. If we have for frozen section biopsy, I would prefer to send the pelvic lymph node for frozen section biopsy. And if that becomes positive, I would proceed with a para-aortic lymph node dissection to get a pathological diagnosis. And if that one is negative, the para-aortic is negative, I will still not do the radical hysterectomy part, but that will give the information to give the radiation treatment. So I would do frozen section biopsy followed by para-aortic lymph node dissection in this case.
Yeah, I think Dr. Alia.
I think I would to add that why we are discussing this case is because preoperatively we never suspected that the lymph nodes are so big. So I think the best practice would be, if possible, I'm saying if possible, we can have some kind of imaging to assess the lymph nodes preoperatively. In our center, we prefer to do MRI pelvis and a CT scan abdomen and chest, and if possible, a PET scan with MRI pelvis in order to do the metastatic workup and to assess the lymph nodes. So PET scan is quite sensitive with such large lymph nodes. And if PET scan is showing high SUV, then high SUV in these large lymph nodes, that gives you preoperative effect that these lymph nodes are positive. In that case, you will not undertake surgery. So my question is, why go for surgery when you have suspected?
Can I have an opinion? Can I have your opinion?
Yeah, just before Dr. Sabra, madam, I just wanted to tell Dr. Alia that MRI for this patient was done, but the nodes were really not very enlarged. But then there were sticky nodes, and then later on dissection they were found to be little suspicious. So that is what happened actually. Next, yeah, Sabra, madam, please go ahead.
Oh, I want to say a few words regarding this case, that to know preoperatively to know about the lymph node is very difficult, because the radiology and imaging experts are not so much.
Yeah, sometimes they are mistaken.
Sometimes they mistake one thing. And during operation, another thing is that if there is no fusion section facility, by only naked eye examination of the lymph nodes to assess whether the lymph node is involved by the malignancy or it is inflammatory in enlargement of the lymph nodes, it is also very difficult. So if my opinion is that if it is possible to remove the enlarged lymph node very easily without injuring the vessels, then enlarged lymph nodes should be removed, and surgery proceeding to completion of the surgery, that gives the better result, my experience. And I think evidence also shows that it is removal of the lymph nodes, enlarged lymph nodes, is better than the abandonment of the surgery.
I think we had a wonderful discussion on this. There are two more hands being raised. It's Dr. Uzma, followed by Dr. Jitendra, and then we'll quickly go ahead with the evidences.
Thank you. Thank you, Dr. Chavan. So I just want to add a good practice point. In our center, where Dr. Ali and I am working, we always discuss all our cervical cancer patients in multidisciplinary tumor board before taking them to theater. So if the diagnosis is made with the cervical biopsy beforehand, then discussing them in the tumor board with expert gyneco-oncological radiologist and radiation therapist would give the better decision regarding the primary treatment of the patient. Thank you.
Yes, Dr. Jitendra.
Yes, I just wanted to add, supporting the previous views, like bulky nodes, if they can be removed, should be surgically removed, but radical hysterectomy should not be done in favor. Rather, CCRT should be the main modality of treatment.
Okay. Bhatia, you want to say something? Please go ahead.
Yes.
Can you unmute your...
Can I add? Can I add anything?
Yes, Dr. Shana.
Yes.
Yes. Actually, it's what we are discussing during that time, that it is the ideal situation. But what is in our situation, like Dr. Bhagalokhi, Doctor and me, where we are working, always it is not possible for us to assess this and preoperatively to do the frozen biopsy. And another, it is not possible. There is only in case of the imprint cytology, it is only the comparable with an ovarian malignancy, but not in the lymph node, because sometimes in inflammatory lymph node and also the metastatic lymph node, it cannot be assessed even after the advanced imaging. So in that situation, we are talking about what is the ideal situation, that is we should send the lymph node for frozen biopsy, and if it is positive, but there are some studies where showed that if they're bulky lymph nodes, large lymph node, and we can do that. And there was a study which was done in Singapore and also in Japan, where they showed that in bulky lymph nodes, if after removing that, and after that, if there is chemoradiation abundant, there is radical hysterectomy, their outcome is better. So we should think in our situation, and our situation, the advanced imaging after, and we to take the proper decision.
Okay. I want to also discuss two questions which have been asked. Bhagya, if can we take those two questions? One is from Dr. Namka regarding the incision to be taken for a radical hysterectomy, so that the approach to the para-aortic lymph node, which one is better, the vertical one or the Maillard's one? Any one of you can answer that? Hello.
Definitely, it is vertical one.
Yeah, I think the Maillards will not be, we will not be able to approach the
Mallard will not
para-aortic.
able. Yes.
Approach the para-aortic. So, and but then you can have that inverted J. So the J incision can be given, but then we usually, it's not a practice to do para-aortic lymphadenectomy.
Yes. So now there's one Aisha Sabha. She has mentioned here pre-operative lymph nodes are on the basis of sentinel lymph nodes or grossly enlarged lymph nodes only. I think Bhagya, hello.
Yes. Can you
Uh,
hear me?
Dr. Aisha Sabha, she has mentioned here her question. Pre-operative lymph nodes are on the basis of sentinel lymph nodes, or are they grossly enlarged lymph nodes only? It is one question which is there in the chat box. You can answer that later. So can we go to the slides now? So that basically the 2 points are here. Either you should continue with the surgery and
Can I answer that? Usually the sentinel lymph node mapping in case of the cervical cancer, it is still in a study. It is not yet proved that there is a sentinel lymph node. Only in case of the early stage disease, that is stage 1, A2, where there is LVSI positive or the fertility sparing surgery, or in other cases, in that cases, there is the sentinel lymph node. Otherwise, they always not yet, it is not proved the sentinel lymph node in case of the cervical cancer.
okay.
Yes. And Dr. Shannon, just to add to something that there are centers who usually do the lymphadenectomy first, send it for frozen and wait for the report, and then plan for the surgery. But in case
it is the ideal. Yes, it is the ideal.
Sentinel to this, so the work of the your pathologist will be less. So that if they do sampling of that node, if node is positive, so the work will be little less. So I think we all agree that if there is an enlarged node in our setup, we should ideally, if you have a radiation facility, as Dr. Shana has told, that if you have a radiation facility, it's always better to abandon the procedure. But on the other hand, first-hand information would be that if you abandon the procedure and leave the growth behind, it's suppose a 4 centimeter growth, you're leaving it behind. Patient has wound infection, takes 3 weeks or 6 weeks to heal, and then so the radiation times gets delayed also. So that's again another scenario which you have to look at. So I think this is again another Abrax trial which has again showed that the recurrence-free survival are the same. So the take-home message is that adjuvant chemoradiation is required for the completion of treatment after hysterectomy with node-positive cervical cancer patients. Radical hysterectomy completion does not improve oncological outcome of the lymph node positive cervical cancer patients. So, but finally, we would be giving them dual modality of treatment, which causes really additional morbidity. So, I think surgery and then radiation actually lands the patient in very ghastly radiation reactions. So I think again we have to think about that, and always single modality of treatment is the best treatment. So this is one of the patients in which we had done sentinel lymph node, and this node was positive, and we have abandoned the procedure. So I think let's go to the next case. So Dr. Niranjan. Yeah, so case 4 is she's Mrs. X, menopausal for 15 years. She had a bit of prolapse symptom for the last 23 years, but suddenly there was little pain during defecation and maturation, for which she has attended OPD, and the ultrasound showed a little lower-lying uterus, and she has undergone vaginal hysterectomy with pelvic floor repair on 19th of September 22. So this is the ultrasound report. But unfortunately, again, the histopathology showed a moderately differentiated grade 2 and depth of invasion was 7 millimeter. LVSA was not identified. Entire histopathology report was perfectly mentioned. Uterine corpus involved by the tumor, bilateral parametrium was free. Endocervical margins with vaginal cuff were free of the tumor involvement. So all these findings are very favorable. So Dr. Sampath madam, are you there?
Yes, Bhagya.
Yeah. So she was a case of second degree prolapse, and then she went to a doctor and underwent a vaginal hysterectomy with pelvic floor repair. So did we go wrong anywhere?
No, here it is the complaints is for more than 23 years. And
the prolapse was there, yes.
Yes. So in that cases, in our hospital, what is better to rule out the cervical and endometrial pathology. Cervical biopsy and endometrial biopsy could have been taken before going for the hysterectomy. Anyway, we are going to do the hysterectomy only. I think if the biopsy would have done, then we can see whether the nodal involvement and everything can be done. That is my opinion. You can assessing the case before surgery is very, very important. History taking and simple, if now needed, if a biopsy has been taken and the biopsy report was like this, then you can do that, whether nodal involvement are there, then we can plan whether to go for hysterectomy.
Yeah, I think two things. We have to, a message should go that all women who are having a hysterectomy, irrespective of what is the cause, I think a good look at the cervix and a pap smear should be done before we do any kind of surgery. So that we should understand. But then this woman had a report of cancer. Maybe due to communication gap, either she didn't understand or her consultant did not understand. So patient attended our OPD on 23rd, on November 23rd with complaints with the report. So on clinical examination, everything was normal and a wart smear was taken and the vaginal mucosa was smooth but it bled on touch, but there was no definite mass was palpable. So Dr. Rajita, any suggestions? Because she was operated in 22, came to us in 23 with the report of a squamous cell carcinoma. So I think we should, Dr. Rajita, are you there?
Not the right thing. Then we have to go with radiotherapy.
Yeah, the consultant should take responsibility that if there is a report of squamous cell carcinoma after any vaginal hysterectomy, we should take responsibility and counsel the patient to reach out to some other oncologist who can give a better treatment modality. So
yes, I think with the second presentation, because it's quite, after some time from the initial surgery and there has been a lag, before we plan on any surgery, we need to do the imaging to make sure that, like, if you're going for a radiotherapy, it should be for a localized disease. So we need to know whether it's a localized disease at this point or whether this is now more, spread towards, to the other parts. So
yeah, Dr. Rajita, we have discussed all that. I just wanted to point out about the delay because she was operated in 22 and came back with a histopathology report of a squamous cell carcinoma in 23 to our OPD. So I think the delay, who is responsible? The patient, the clinician,
I think the clinician should take complete responsibility
as
in
health
that situation.
providers, it's our duty to close this gap. We have to counsel them that because she came in 23, she could have come a little earlier. So now wart smear was suspicious of squamous cell carcinoma and the slide review confirmed the histopathological findings and she was P16 focally positive, P40 was positive, P53 positive and ERPR was negative. And so, and the PET-CT showed a hypermetabolic hypodense nodular lesion in the vaginal vault called likely residual disease of size 1.5 into 1.5 centimeter with a SUV max of 4.5. So patient was referred to CTRT and patient received 25 fractions EBRT and 3 fractions brachy and last dose was on 19th of January and patient is now on regular follow-up and of course thankfully she is good. But I think we should understand that inappropriate management of cervical cancer, when we think that there is radiation to take care of everything. It is not so, because we have seen many reports. Dr. Giri sir has also mentioned in some of that inappropriate hysterectomy followed with radiotherapy will not give you the same survival as compared with the primary treatment of CTRT at the beginning. So Dr. Niranjan, please take the case 5.
Thank you. I think if time permits, can we take this case, Alia ma'am?
Dr. Alia?
Can we?
I think we should stop here because
Okay.
4 cases.
Okay.
Four cases has been discussed. Very interesting cases.
Okay. Dr. Bhagya and all the panelists, I would like to thank all of you to be present here today. And we have done a wonderful presentation and panel discussion. There are the slides are available for all the panelists in the group. You can continue to go ahead, and if there are any questions by the audience, we can surely share with them also your opinions. So basically, we should see whatever
I
best.
would like to say a few words.
Yes, sir. Yes, sir. I'm just concluding.
Okay, what I would request you is, since it's a very interesting discussion that we've had, I'd
Yes.
suggest that we put up this particular webinar on our SAFOG website.
Yes.
So that people can access it whenever they want to, and advertise it adequately. So even those people who have not been able to attend today's webinar will be able to gain its advantage.
Absolutely, sir. And this is live on YouTube presently. The YouTube movie, we will download it, and we will pass on to SAFOG office so that they can upload on the social media and the YouTube channel. Also on the official Shield Connect YouTube channel. This is also available, sir. So I'm sure many people, as soon as the program is over, the host Shield Connect will immediately post it for the viewers' benefit. Dr. Alia, thank you so much for giving India the opportunity to hold today's World Cancer Day, CME, and thank you, Dr. Bhagya, for giving this wonderful insight on, and all the panelists to be there today. I hand over the mic now to our expert commentator, Dr. Sabira Khatun, who has been kindly.
Niranjan, please give me 1 minute before we end. I think one important case we have missed out due to shortage of time. But the only thing about laparoscopy, because that's coming in a big way. So I think doing lap radical surgery is now against the evidence. We have the very infamous LAC trial which showed that the recurrence rate and the death rates are much higher than that of open surgeries for CS cervix. So I think that that is a message that should go out, because our younger colleagues are very interested to do radical surgeries. So I think until we have further evidence, I think we should try to restrict ourselves to open surgeries for cervical cancers. So thank you so much, sir.
Can I add one point as well? Another important point.
Yes, madam.
Yes, I think because of shortage of time, we didn't talk much about the CONSERVE trial and the SHAPE trial. I would encourage all the participants to go back and read the SHAPE trial, which is recently presented in the ASGO meeting, and the recently published results, because it does give us guidelines about the less radical surgery for cervical cancer. And I think the SHAPE trial has very important laid down criteria in which we don't have to do radical hysterectomy. So I would encourage everybody to go back and read the SHAPE trial.
Thank
Anyway,
you.
congratulations, Alia. Congratulations, Alia.
Thank you, sir.
Okay, and we should also plan a similar interesting topic for our next webinar.
Yeah. I have this talk that if we give this message to our general OBGYN people that more conservative surgery in case of the cervical cancer, then they will think that the simple hysterectomy, hysterectomy, that is enough for the less than 2 centimeter of the growth. But even after that, they don't know without knowing that which one is the ideal, the stage 2 is less than 2 centimeter. And not only that, we can go for the simple hysterectomy by showing that the either conization or the lip biopsy, there is no growth in only in that cases. Otherwise, they invariably, they routinely do simple hysterectomy. Oh, it is 2 centimeter, suggesting 2 centimeters. So we can do the simple hysterectomy.
Easy for them to rationalize what they are doing.
Yes.
Thank you.
I think that's for institutions to follow now.
Thank you,
before
Bhagya
we-
Lakshmi.
Thank you, sir.
Thank you, everybody, for their nice comments. I would like to give some simple words about the webinar. It's very helpful for the countries like Bangladesh, India, Pakistan. It's very helpful. I would like to give, first of all, give thanks to the chairperson of this webinar, Professor Alia Aziz, then President our President SAFOG, Professor Shyam Desai, and General Secretary SAFOG, Professor Farhan Abdewan. Everybody was present in this webinar and gave their valuable speech in this webinar. We are very much encouraged by their speech. And the first session, the keynote speaker, Dr. S.K. Giri, very elaborately described about the surgical procedure, about the other things of cervical cancer. And one thing of Dr. S.K. Giri, I want to emphasize and to remind that about the among the 190 cases, only 67 cases had the biopsy, cervical biopsy, and rest of the cases was diagnosed after hysterectomy. It's very alarming for us, for in all the doctors, all the OBGYN specialists and gynecologists in this region. It's very alarming situation. So we should be very alert about we should be very careful about the taking biopsy from the cervix before going any hysterectomy, any type of abnormal bleeding, discharge. We should have proper evaluation of the cervix. And after 4 cases was discussed in this webinar, and all the cases are different types and different lesson we have obtained from these case discussions. And last of all, about the SAFE study in the ASGO, the SAFE study, the decision was that it is not concluded. It is not concluded, and this study should be continued, and the conclusion will be made later on. So we should not know about the, we should not say about the SAFE study to do his simple hysterectomy for cervical cancer. The Professor Shahana that said it is very important for our country, especially for our country, because all the gynecologists will go for simple hysterectomy for cervical cancer, and that would be very much a tremendous loss of their life, and very it will very hamper the treatment of our simple poor patients of our country. So last of all, I would like to give thanks all the special panelists. I do not want to say the name of the panelists. All the panelists have their valuable opinion. And lastly, Dr. Niranjan and Dr. Bhagyalakshmi, their very valuable opinion, valuable comments. We are encouraged by their comments. Thank you very much, Dr. And last of all, I want to give thanks to our President, Shyam Desai sir, that he has mentioned that we should circulate the things throughout the members of the SAFOG countries. It will be very helpful for the SAFOG countries, I think. Thank you, sir, for your nice opinion and nice suggestion. Thank you all for this webinar, especially Bhagyalakshmi, Niranjan, Alia, Aziz, everybody. Thanks very much from my part. Thank you very much.
Thank you so much. Thank you.
Thank you, everyone, for joining this